Hi, everyone. My name is Lonnie Zwaigenbaum. I'm a developmental pediatrician at the Glenrose Rehab Hospital in Edmonton and also on faculty at the University of Alberta. And I am delighted to introduce my colleagues, Dr. Jessica Bryan, who's a psychologist at Holland Bloorview Kids Rehab and on faculty at the University of Toronto, and Dr. Angie Ip, who works at the Sunny Hill Health Center at BC Children's Hospital, a developmental pediatrician and also on faculty at the University of British Columbia. And we're grateful to CASDA and the Leadership Summit Organizing Committee for giving us the opportunity to present today, and to all of you for taking the time to participate. So anchored in the recent Canadian Pediatric Society statements, our presentation will focus on how models of assessment can be tailored to individual needs and community strengths in order to accelerate the diagnostic process and improve access. We'd like to start by posing a question that helped guide us as a task force. How can we improve our system of care to ensure that high quality assessments are more accessible across the lifespan? It will be great to get your thoughts on how assessment and diagnosis could be improved in your communities across Canada and further extended to ensure access to assessment and quality care for autistic adults. Although there have been advances in early detection of autism and some families are able to access a diagnosis at an early age, there are still major gaps as well as fragmentation in the system. Most families recognize initial signs of autism before their child is 2, and yet recent Canadian and US data suggests that the average age of diagnosis has barely budged from age 4 to 5. The timing of diagnosis varies by severity of developmental challenges, but there are also disparities related to ethnicity and socioeconomic factors. And we are painfully aware of the lengthy wait list for diagnostic assessment across the country. As well, after diagnosis, children and youth on the autism spectrum are less likely to have a medical home, that is a trusted pediatrician or family physician who attends to their health needs, compared to other children who receive specialized care, such as children with asthma or diabetes. And we're also aware that the access to diagnostic assessment as well as medical care is even more challenging for adults on the spectrum. So autism diagnosis has traditionally taken place in highly specialized centers, which provide high quality and often multidisciplinary assessments. But the reality is that increased numbers of specialists and subspecialists working at these centers have not kept up with the number of children being referred. And for families outside of major urban centers, access is a major challenge. One of the major themes of these practice statements is the importance of partnerships between specialty teams and community professionals to help create an integrated system of care that tailors assessments to the needs of individual children and family and promotes holistic care closer to home, including continuity of health care. So we were part of a task force through the Canadian Pediatric Society that was charged with developing guidelines for assessment throughout the life course, with the scope focused on early detection, diagnostic assessment, and ongoing assessment needs as children move through adolescence and ultimately transition to adulthood. The process started with a comprehensive review of relevant research focused on assessment at various stages, as well as variation in care models and criteria for access to services across Canada, led by the Public Health Agency of Canada. Although our scope was limited to early detection, diagnostic assessment, and ongoing care, the whole process certainly got us thinking about broader issues in autism care. The representation included a wide range of professional group and parent leaders from the Canadian Pediatric Society, College of Family Physicians of Canada, Canadian Academy of Child and Adolescent Psychiatry, Canadian Psychological Association, as well as a parent leader representative from CASDA and as well as other parents, many of whom had multiple roles. Here's a list of the participants and members on the task force that includes Angie, Jessica, and I, other pediatricians representing the developmental pediatric, community pediatric, and mental health sections of the Canadian Pediatric Society. And you can see other people listed here representing other disciplines, as well as Sheila Laredo, a clinician scientist, and also a parent representing Canadian ASD Alliance, and another parent leader, Susan Cosgrove, who is based at Bloorview Kids Rehab. So the first statement is on early detection of autism, and again with a focus on young children, but I think with implications for thinking about broader lifespan needs. So the task force ultimately proposed 3 levels of assessment that builds on the Canadian tradition of developmental surveillance, which is a process of monitoring a child's development over time in the context of ongoing care, and informed by clinical judgment that draws from multiple sources of information, including dialogue with parents, structured assessment tools, and careful observation. The first stage is general developmental surveillance. So that is monitoring general development and early signs of autism. And there's a list of appropriate tools and encouragement for clinicians described in the guidelines. The second stage is autism-focused surveillance. So that is when any concern relevant to autism is identified, so around communication or social development or play or differences in behavior, this should trigger a more in-depth assessment for autism symptoms, including the use of structured early detection and screening tools such as the MCHAT. The next stage is diagnostic assessment, and a really key point, which Dr. Bryan will elaborate on further, is not only are community physicians involved in the surveillance process, but they may play a fundamental role in the diagnostic assessment itself. And then critically, there's a link to intervention services throughout, so ensuring that children at the first signs of any concerns are linked to local interventions in their own community with support for parents to navigate the system. And what are the earliest signs of autism? Well, we've certainly learned a lot from parents over the years who've really been our primary source of information and our touchstone in terms of their descriptions of what their children were like early in life. And this information is now supplemented by research of early signs of autism in infants with older siblings with autism. Our research group, for example, and many other groups internationally have found that there's a number of early signs of autism that can be seen by the first birthday. And to some extent, these map onto the 2 broad domains within DSM-5. So thinking about early communication and social development, as well as behavioral differences. So infants who go on to a diagnosis of autism often don't respond when their name is called. They may be quieter and not participate in back and forth babbling. They're more difficult to engage, not making as consistent eye contact, not sharing joyful expression and participating in back and forth interaction. They may not look back at their parent when they're exploring a new situation or meeting new people. And then some specific behavioral challenges. So difficulty transitioning between activities, getting stuck or over-focused on a particular toy or other objects. Often this over-focus is associated with intense sensory exploration, both visually or using their tactile senses. And in general, children with autism may have difficulty visually exploring their environment because of this tendency to become over-focused on particular things. Our proposal around autism-focused surveillance is really in contrast to the current recommendations through the American Academy of Pediatrics. And we really embrace our early detection guidelines as a made-in-Canada approach that really emphasizes the pivotal role of parents, the expertise of community professionals, and working together as a team. The American of Pediatrics has recommended universal ASD screening, but the truth is uptake has been poor, and recent extension of initial research into community settings suggests relatively low sensitivity, so the number of children that are picked up, and also relatively low positive predictive values. So to some extent, the screens may over-identify children with autism, and the relative proportion of children flagged by the screen who end up having a diagnosis is low, which has led to some pushback from the assessment system. Within our guidelines, we really focus on a more flexible process of surveillance that integrates these screening tools into the professional practice of community physicians and other professionals, working with parents to help ultimately inform decisions around further assessment and referral. Critically, when we circle back to the original question of why is there such a gap between when parents identify concerns and when children are diagnosed, why is there that gap given how much we've learned about early signs? For many years, we've emphasized increasing awareness about early signs of autism as really being the main route to earlier diagnosis. But this is really a relatively indirect approach and makes the assumption that the key barrier to diagnosis is early recognition, which really isn't always the case. Increasingly, the main bottleneck in the system is access to diagnostic assessment once initial concerns are identified. How do we tackle these challenges more directly through innovative approaches that build diagnostic capacity through community partnerships? And with that, I'll turn it over to Dr. Bryan to discuss diagnostic assessment.
So I'll be sharing with you sort of the highlights of our standards of diagnostic assessment from the guidelines. And really, we highlight in the guidelines 3 approaches to diagnostic assessment that help us think about ways that we can ensure quality care while also sort of maximizing some of the challenges around access to care and improving access. So we describe a sole practitioner model in which you know, an individual physician or psychologist might make the diagnosis independently. Usually this would be in situations where the cases are more clear-cut. And the individual clinician would be using clinical judgment and sort of positioning that against the DSM-5 criteria. And often in this type of situation, there may be referrals that are necessary for specialized care or for further assessment in cases where the diagnostic determination is not so clear-cut. We describe a shared care model in which the physician collaborates with other practitioners in the community. And in these kinds of cases, the primary care provider might have access to information from standardized tools in collaboration with other providers in the community. And this type of model would be most appropriate for cases that are a little more complex, such as perhaps girls and children under age 2, where the symptoms may be a little bit less clear-cut. Finally, we talk about team-based approaches, which could either be interdisciplinary or multidisciplinary teams of individuals from multiple disciplines working together to really put their heads together and understand the more complex cases, particularly those cases where the symptoms may be much more mild, or there may be co-occurring mental health or sort of psychosocial factors that play into making a diagnostic determination. We do note that the team-based models are often required in particular jurisdictions across Canada for accessing services. And you'll see in the statements that we sort of talk about that balance or the tension between providing this level of care and sort of trying to maximize access and reduce wait times for assessment and diagnosis. So in the statement, we sort of really try to highlight what the purpose and the priorities are in a diagnostic assessment. We really sort of identify 4 pillars. One, of course, being determining the determination of a definitive diagnosis. We highlight the importance of exploring co-occurring conditions and sort of ruling out those conditions that might mimic ASD. We talk a lot about the benefits and the processes involved in determining an individual's sort of overall adaptive function, their strengths, their challenges, their interests, and then really sort of helping to gather sufficient information, be it from the original source of the assessment or from other sources in the community that inform treatment planning. And all of these pillars really are grounded around the concepts of providing child and family-centered care that's culturally sensitive and culturally safe. So in our statement, we highlight 8 components of the diagnostic assessment, and these include detailed review of records from all sources from which they're available, interviewing, so oftentimes it takes place with parents or the child themselves, also pulling in teachers, childcare staff, and any other providers who are able to share information about that individual. Obviously, one of the key components is the assessment for those core ASD features, and we do highlight sort of the importance of, in addition to the interviewing and getting the really detailed developmental history that's focused on ASD core symptoms, we do talk about sort of the importance of that direct observation and interaction, which, depending on the model and the system and the jurisdiction and sort of all the factors that I just talked about, really may involve standardized measures, or in some cases might not. The 4th element involves a comprehensive physical exam and additional investigations to sort of rule in or out co-occurring conditions. And then, of course, establishing the diagnosis. And we go into some detail around communication of the findings and how that's shared with families in a way that allows families to partner with the person providing the diagnosis and really make sure that they understand the diagnosis that's being communicated to them and the next steps. We highlight the importance of intervention planning, which may take place at the point of the diagnostic assessment, but also may involve or require referrals for other assessments depending on the individual needs. So really in sort of thinking about some of the key factors that affect individual access, timeliness, and accuracy of the diagnostic or the diagnosis and the diagnostic assessment, we know that age factors play a role. So some of the very young children may have milder symptoms or may be harder to make a definitive diagnosis. And we talk about the importance of provisional diagnoses and some of the follow-up care that might be needed when a provisional diagnosis is provided. We do also highlight that diagnoses can be made before age 2, and it's important to do so in cases when clinicians are more certain. We talk about differences in sex, so we know that girls may be are diagnosed later, and their symptoms may be a bit more subtle and more difficult to determine early on. And then, of course, thinking about sort of some of the disparities that families encounter from rural or remote regions, as well as some of the cultural, language, and socioeconomic disparities that families face, all of which can affect individuals' access to timely and accurate diagnostic assessments. So now I'll turn the podium over to my colleague Angie Ip, who's going to talk about management and treatment.
So thank you, Jess. The third part of the statements focuses on post-diagnostic management and follow-up care by the community physician or pediatrician, who are an important part of the medical home for autistic individuals and who often play a vital role in helping families access services. Our recommendations for post-diagnostic care centers around child and family-centered care with the guiding principles of enhancing the quality of life for individuals and their families. We covered 4 main areas. So one is the management of medical and psychiatric comorbidities, supporting access to behavioral and developmental interventions, referrals to supportive social care services, and also communicating with other healthcare professionals, therapists, educators, and service providers. More specifically, we break down our recommendations into 8 main components. So completing etiological testing for associated medical conditions if they're not already done during the diagnostic process. Managing comorbid conditions as they come up. Assisting in referrals for other assessments and therapies that address functional challenges, for example, speech and language therapy or occupational therapy. Making referrals for behavioral and developmental interventions. Managing challenging behaviors, which includes anticipatory guidance for these behaviors. Counseling on complementary and integrative health approaches. Helping refer families to family and other support interventions, including educational resources, community supports, and funding applications as needed. And finally, obtaining and sharing information with parental consent with school and community teams, especially during major life transition periods. This is a summary checklist we created for clinicians based on our recommendations as a guide to post-diagnostic management. It's currently available for download on the Canadian Pediatric Society website. So we also had a few more key guiding principles for post-diagnostic care. In our recommendations, we encourage the active monitoring for comorbid conditions, as many autistic individuals don't always present with the common signs and symptoms. We also recommend that behavioral interventions be initiated as early as possible, ideally even before a diagnosis is confirmed. And interventions themselves should focus on individual needs as they evolve over time, with the ultimate goal of ensuring that individuals can participate fully in life at home, school, and in the community. We also stress that medication use should only be considered when non-pharmacological strategies have been exhausted and should always be used in combination with behavioral interventions. And finally, we reiterated that many families and children with ASD and autistic individuals experience greater stress and financial hardship. Therefore, healthcare providers should be familiar with local, provincial, and federal programs that provide financial assistance. Again, the ultimate long-term goal is to enhance quality of life for individuals and their families. And with that, I'm going to pass it back to Dr. Lonnie Zwaigenbaum.
So finally, we'd like to end with some considerations for later childhood, as well as implications for building a care system for adults. So some considerations for later childhood. So first of all, there are some groups of children that are diagnosed at a later stage. So in particular, children with milder symptoms, those with stronger language and intellectual skills, and that's particularly the case for girls and young women. Many of whom somehow master the rules of social behavior and are able to mask their ASD symptoms, but at a real cost in terms of the amount of mental energy and the risk of mental health issues among these youth and young women. We also recognize the intersection between gender diversity and neurodiversity, and increasingly we recognize that there are higher rates of gender differences, gender dysphoria, as well as non-binary gender identities among autistic youth and adults. And we also recognize that within gender programs that there are youth with traits and symptoms of autism that are being identified. We also recognize that young people with autism, even those that are doing really well during the preschool years, may run into later challenges during the school system, and in particular, emerging learning disabilities and mental health challenges that may not be apparent at an earlier age. It's also important to acknowledge at a time where we're experiencing challenges related to the pandemic, as well as cuts to services in many provinces, that we need to continue to support and advocate for the safety, dignity, and opportunities for all youth, including youth with autism, to have the full opportunity to participate, to access supports, and to perform and achieve to their potential, particularly in the face of these challenges. And finally, we play a really critical role in terms of the transition to the adult care system. Sometimes we talk about the focus on the pediatric office, and family physicians don't have such a substantial role supporting children with autism, and this creates further challenges as autistic youth are transitioning to primary care. We need to build capacity within the primary care system, and as we look ahead to the types of healthcare challenges that adults with autism face, we need to recognize that health issues in that group are influenced by the same factors that affect health in the general population. And it's not the biology of autism, but rather the marginalization, the lack of opportunity to engage in the workforce and participate in social and recreational activities that put adults at higher risk for many chronic illnesses. In thinking about the diagnostic system for children and youth, we need to really work together to build such a system for adults. We really do need to shift our emphasis from early diagnosis to timely diagnosis, recognizing that the diversity and variation in presentation suggests that we do need to build a system of care across the lifespan. Similar to what we've proposed for children and youth, we really need to develop a diagnostic system that includes multiple linked streams. Sort of at one end, the regional centers that have highly specialized teams, but we need to start now to actually build capacity within the community and even within physicians' office to orient to features of autism and also start to build community assessment models that would support better access to diagnosis. And then, of course, we need to expand focus beyond assessment and beyond the health system. If we're really supporting the well-being of people with autism across the lifespan, we need to address issues around schooling, employment, and housing, to name a few. And then finally, if we're going to build an effective system that supports the assessment and access to services and care for autistic adults, we need to do it from a position of strength and partnership. And that is involving autistic adults in key leadership roles, as well as parents who play such an important part of their lives, and also work across disciplines. We need to sort of take the lessons from these many years that we've tried to develop a more integrated and coordinated system of care for children and youth, and make sure that we don't leave autistic adults waiting on the sidelines. And we need to dramatically accelerate that process so that we truly have an acceptable and quality system of care for people across the lifespan. So many thanks to all of you. A special acknowledgement to the Public Health Agency of Canada, who supported the launch of this process, including the systematic review. And this whole process was really the brainchild of Dr. Marianne Offner, a clinical epidemiologist with the Public Health Agency. We thank, of course, CASDA and the leadership of CASDA in providing us the opportunity to participate in the summit. And then, of course, special recognition to the Canadian Pediatric Society, who supported the creation and establishment of this task force, as well as our colleagues whose insights and sensitivity and systems thinking really led us to these statements, which we hope will provide a blueprint forward in terms of building capacity and greater access to autism assessment and care throughout childhood and ultimately throughout the lifespan. So thank you.